So, like many practitioners, we're somewhat restricted to what we have available to us. We have recently published guidelines in the British Journal of Haematology for the British perspective on the treatment of Waldenström's as a whole, including relapsed refractory disease. There is quite a wide menu of potential treatments, but that has to be, there's a reality check about what's available. So I think chemoimmunotherapy is still a very potent and really effective approach, both in frontline and relapse. The competition is coming from targeted therapies, but there is the availability issues. So the reality in the UK is going to be, Brutonib is a kind of a BTK that we can use. Otherwise, agents like Bortezomib, that we have actually done a recent review of our experience, can be, in my opinion, very, very useful and not quite as toxic as people fear, as shown in our data. And I believe it depletes plasma cells as well as CD20 positive cells. So I think it works from a different angle in the WM setting, and used with care, I think that is a good approach. In other settings, we do consider, in high-risk patients, we will consider more intensive chemotherapy in our practice, including consideration of an autologous stem cell transplant, especially the patients are young, 40, 50. At that age, they've got a long way to go, and we need to be very careful in using therapies in a judicious way, in a sequential way, not burning our boats, keeping options open, and perhaps allowing some of the newer therapies to show their true colors with longer follow-up.